So hi guys, there was a delay in recording the video because I had some record work, so I need to submit it tomorrow. Yeah. So today we are going to discuss a case. A mother brought a child to OPD with the complaints of fever with chills and rigor, and she complained that the temperature was going high and coming down, and by the time of coming down, it is producing intense sweating. Yes, you are at the right diagnosis, that is malaria. So here I am giving clarity to you that I am going to discuss about the microbiology as well as the pharmacology aspects of the malaria, so that an overall view of malaria is being given to you, right? So let's get started. So hi guys. So first we'll discuss about the word malaria. So the word malaria, we have mal, which is meaning bad, and area, which is meaning air. So the meaning of word malaria is bad air, right? So we have, first we'll discuss about the causative organisms of malaria, right? So the causative organisms of malaria are, we have Plasmodium vivax, Plasmodium falciparum, Malariae, and Plasmodium ovale and Plasmodium novelaceae. So here we have to discuss is Plasmodium vivax causes benign tertian malaria. Plasmodium falciparum causes malignant tertian malaria. Plasmodium malariae causes benign quaternion malaria, and Plasmodium ovale causes tertian malaria. So in Plasmodium ovale, we have two species. One is Plasmodium ovale, subspecies is Vallicari, and second species is Krupski, right? So these two are the subspecies which are discovered in Plasmodium ovale. So next we have Plasmodium novelaceae, which causes Simon malaria. So what is the meaning of this Simon malaria? So Simon malaria means the fever which is there, malaria fever, it reoccur every day. So this is the meaning of Simon malaria. So the fever which is present, it will reoccur every day. So that's the meaning of Simon malaria. Now let's go into the life cycle of Plasmodium. So further we'll discuss about the clinical features, laboratory diagnosis, and treatment of the Plasmodium vivax, that is malaria. So for that, this is the basic for that. So you need to understand this life cycle of Plasmodium to understand the malaria. So we have, first we'll start with the host, right? So it has two types of hosts. One is definitive host, that is female Anopheles mosquito, and there is an intermediate or secondary host, that is humans. So what happens? Why we are calling the female Anopheles mosquito as the primary host? Because you can see the sexual life cycle. So the sexual life cycle is happening in the female Anopheles mosquito, whereas the asexual life cycle is happening in the humans. So let's dive into the life cycle of Plasmodium. So the female Anopheles mosquito, the bite of female Anopheles mosquito causes the release of sporozoites into the circulation. So these sporozoites, they go and they infect the liver, right? So in liver, the hepatocyte, they infect the hepatocyte, they are inside the hepatocyte now. Now they form the trophozoites which are present inside the hepatocyte, and these trophozoites, they form the pre-erythrocytic zygote, and this pre-erythrocytic zygote, they form the hepatic merozoites, and which are released by the rupture of hepatocyte into the circulation. So these are the merozoites which are released into circulation by the rupture of this hepatocyte, right? And now this merozoites, they infect the RBCs. Since you know in the circulation we have RBCs, WBCs, and platelets, these merozoites, they infect the RBC, right? So these are the merozoites which infect the RBCs, and this is inside the RBC. They reach the inside the RBC, and now they form the ring form, late trophozoite, immature zygote, and mature zygote, and finally they are released into the circulation again. Now these are called as erythrocytic merozoites. So these erythrocytic merozoites have two fates. So they may be infecting the RBCs again, or they may be forming the gametocytes, right? So these gametocytes may be, with respect to Plasmodium ovale or Malariae, they have male and female gametocytes, With respect to falciparum, also we have male and female gametocytes. Now what happens is these gametocytes are taken up by the female Anopheles mosquito again. When the mosquito is biting the human being, so these gametocytes are being taken up by them, right? So by taken up by them, and they form the macrogametocyte and microgametocyte. There is fertilization, and in the midgut of the mosquito, so in the midgut of the mosquito, there will be the development of oocyst, and mature oocyst with sporozoites which are there, they travel to the salivary gland of the female Anopheles mosquito. So again at the time of bite, they are released into the circulation of the humans. So this is the entire life cycle of the Plasmodium. So now here I am going to give you a basic introduction to the treatment of malaria here itself, right? So you can see this cycle from sporozoite to hepatic merozoite. So this cycle is called as pre-erythrocytic cycle. So this pre-erythrocytic cycle, the inhibitors of this cycle, so the drugs which act on this cycle are called as tissue cytogenticide. So this is a hepatic tissue, right? So these are called as tissue cytogenticide. I will discuss the drugs which come under tissue cytogenticide shortly, right? So we have primaquine and tefenoquine. These two drugs are especially effective with this exoerythrocytic cycle. So now I have written a word relapse here. So what is the meaning of relapse? So actually this may be acquired from the female Anopheles mosquito, or especially with the Plasmodium malariae and Plasmodium ovale. What happens is this sporozoite which is there, it is stored like when you have excess money or you want to do savings, right? Same way, this Plasmodium ovale and malariae, they just store the sporozoites in the liver in the form of hypnozoites, right? So these sporozoites are being stored in the form of hypnozoites in the liver, and whenever this see, first a patient will come to you, you will treat, and he will be free from the symptoms. After some time, again the symptoms will reappear. This is because this dormant hypnozoites which are present, they transform into sporozoites again, and they repeat the pre-erythrocytic cycle, and they release the merozoites again, infecting the RBCs, right? So this is called as relapse. We have two other terms, which is recrudescence and reoccurrence. We will discuss it afterwards, right? So this primaquine and tefenoquine, they also act as a gametocidal. So they just kill the gametes which are present. Okay, so we have casual prophylaxis where the sporozoites which are there, we inhibit the sporozoites to reach the hepatocyte or to reach the liver. So this is called as casual prophylaxis. Whereas chemoprophylaxis is, it is induced to kill the merozoites which are released from the liver. So this is the important chemoprophylaxis, casual prophylaxis, tissue cytogenticide, and blood cytogenticide or erythrocytic cytogenticide. This is something very important to discuss here. What happens is the symptoms, the clinical features of the malaria is due to this thing, is due to the rupture of RBC. Due to rupture of RBC, so this all the clinical features which we will see in the further will be due to the rupture of RBC. So we have this blood cytogenticide which inhibit the rupture of RBC, which inhibit this erythrocytic cycle. We have seen this as pre-erythrocytic cycle, right? So this is the erythrocytic cycle which is inhibited by the blood, or you will have a erythrocytic cytogenticide, right? So we'll discuss about the clinical features, laboratory diagnosis, and we have treatment of the malaria now, right? Okay. So let us discuss about the clinical features of the malaria. So as I already discussed the species which are causing the malaria, now let us go into the incubation period of each of them. So we have Plasmodium vivax, which has incubation period of 14 days, and we have Plasmodium falciparum which have incubation period of 12 days, and Plasmodium Malaria, which is having incubation period of 28 days, and Plasmodium ovale, which is having the incubation period of 17 days, right? Now let's go into the clinical features. So it has three different clinical features. One is febrile paroxysm phase, second thing is anemia, and third thing is splenomegaly. Right, now let's discuss about the febrile paroxysm phase, right? So the febrile paroxysm phase which is there, it is the intermittent fever. So what is the meaning of intermittent fever? We have three types of fever, as you all know, that is continuous, remittent, and intermittent fevers, right? So the continuous fever which is there, it is having that yeah, so let's discuss about the intermittent fever now. So the intermittent fever is due to release of the merozoites from the RBC. So I discussed the life cycle, right? So in life cycle, I discussed that due to rupture of RBCs, there is the release of the merozoites into circulation. So the rupture of RBCs, which causes the intermittent fever, which is the cause of this intermittent fever. So we have three different phases in this intermittent fever. One is we have cold phase, we have hot phase, and we have phase of sweating, as we discussed in our clinical case, right? Yeah. So now we have tertian fever. So what is this tertian fever is? That is 24-hour cycle. That is every third day there will be fever. Now for example, if you have fever now, after 3 days, that is third day from now, if you have fever, then it is called as tertian fever. What is quaternary fever then? Same apply, same. You have to apply the same thing, that is, it is 72-hour cycle. That is, every fourth day we will have fever. So I discussed with you this thing, right? So for what species we have tertian fever? Yes, that is Plasmodium vivax, Plasmodium falciparum, and Plasmodium ovale have tertian fever. That is Plasmodium falciparum, Plasmodium vivax, and Plasmodium ovale. Whereas quaternion fever is with Plasmodium malariae. So with Plasmodium malaria, we have quaternion fever, right? Now let's discuss about anemia. Same cause, that is rupture of RBC. What is the definition of anemia? So anemia is decreased oxygen carrying capacity, either due to decreased hemoglobin or decreased RBC, right? So here, due to the rupture of RBC, the merozoites are releasing. So how many merozoites are infecting the RBC? Those all are causing the release, that is rupture of the RBC, which causes the merozoites to release. So we have severe, which is seen with the Plasmodium falciparum. So it damages the all age groups RBCs. All age group RBCs are being damaged by falciparum malaria. Whereas with Plasmodium vivax or ovale, we have young RBCs. So young RBCs are being damaged by Plasmodium vivax and Plasmodium ovale. Whereas with Plasmodium malariae, we have old RBCs. So the old RBCs are being damaged with the Plasmodium malariae. Right, we have splenomegaly. So I have a question with you. Right, I have a question to you, that what are the macrophages in the liver are called as? Yeah, I think so. You know it. That is Kupffer cells, right? Similarly, what are the macrophages which are present in the spleen called as? Do let me know in the comment section, right? So we have macrophage proliferation to remove the parasized and non-parasized RBCs, right? So the splenomegaly, the spleen becomes large or enlarged. That is due to the macrophage proliferation to remove the RBCs which are parasized or non-parasized RBC, right? So this is the about the clinical features. Now let's discuss about the laboratory diagnosis of malaria. So now we will discuss about the laboratory diagnosis of malaria. So yeah, we have microscopic examination and non-microscopic tests. So the peripheral blood smear, what we have, it is a gold standard test, right? So we have thick smear as well as thin smear, as you can see. So we have thick smear as well as thin smear. So thick smear is more sensitive, whereas thin smear, it is used for the speciation. So what is speciation means? It actually differentiates between the falciparum, vivax, malariae or ovale, right? So vivax, how we will identify the vivax is we have amoeboid ring form in case of vivax, whereas falciparum, the very much important and you all know it very well, that is banana shaped gametocyte. Banana shaped gametocyte, and also there will be multiple ring forms or ecole forms in case of falciparum. Whereas in case of malaria, how we'll identify malaria is with the help of band forms. And we have Plasmodium ovale. The name itself tells us everything. See, the Plasmodium ovale. What type of RBCs we'll see? Large oval RBCs, right? So large oval RBCs are seen in case of Plasmodium ovale, right? Now we have quantitative Buffy coat. So it's an example. So you have microscopic examination. We have peripheral blood here. Okay. So the quantitative Buffy coat is nothing but immunofluorescence. So you have to observe them under immunofluorescent microscope. Then we will see the parasized RBCs appear as brilliant green dots, right? So they appear as brilliant green dots, right? Now we have non-microscopic tests like antigen detection test. We can detect the pan-malarial antigen, or we can detect falciparum specific antigen like HRP2, right? And we also have the culture. We have culture with the RMPI 1640 medium and molecular methods very easy, that is PCR targeting 18S rDNA, right? So these are some of the basic things with respect to laboratory diagnosis. Now let us discuss about the complications of malaria, and then finally we will get into the treatment of the malaria, right? So here we are going to discuss about the anti-malarial drugs, as you can see. So again I have bring it to you. See, so this is already I have discussed in the life cycle of Plasmodium, right? Now we are going to discuss about the anti-malarial classification based on the site of action, where they are acting, right? So we have this primaquine and tafenoquine. So these are the two drugs which are acting at the exoerythrocytic cycle. Exoerythrocytic cycle పైన యాక్ట్ చేసేవి these two, this primaquine and tafenoquine, right? And then we have tissue schizonticide which are acting at the merozoites, and erythrocytic schizontacides which are acting on the RBC cycle. See, this is the RBC cycle which you can see like this, or you can go like this. So they can form the male and female gametocytes, or they can infect the RBCs again, right? So here erythrocytic schizonticide, we have two things. One is fast erythrocytic schizonticide and slow erythrocytic schizonticide. What are the examples, or what are the drugs which are included in the slow erythrocytic schizonticide are, so we have PPT, which is a mnemonic to remember the slow erythrocytic schizontacides, right? So what are the PPT drugs that we know is we have proguanil, we have pyrimethamine and sulfadoxine, right? And we have T. What is T? You all know it. Tell me. That is T we have is tetracycline. So these are the three drugs which are included in the erythrocytic schizonticide, that are one is antibiotic tetracycline, and this is you have sulfonamides, and this is proguanil, right? Now we have fast erythrocytic schizonticide, which are, we have mnemonic Machal Q. So you have a mnemonic to remember this fast erythrocytic schizonticide. So what is the mnemonic is, we have Machal Q. So this is the Machal Q that you need to remember. That is mefloquine, artemisinin, chloroquine, halofantrin, atowacone, and you have lumefantrine and quinine. So these are the drugs which are included in the fast erythrocytic schizonticides. So this is the classification of anti-malarial drugs based on mechanism of actions. But in KD Tripathi we have based on chemical structure. So we will discuss about it sometime later, but this is the basic thing we need to understand with respect to the mechanism of action, how the drugs are acting at different sites. And we have this gametocytes. Yeah, so this gametocytes can also be killed by this primaquine and tafenoquine. Right, now let us discuss about the individual drugs. Right, individual drugs which are very important. We have three drugs which we need to discuss. One is this chloroquine, which we need to discuss. Then artemisinin combination therapy, which is very important to be discussed. And also we have, uh, yeah, so these two, and quinine. We have to talk some words regarding the quinine also, right? So let's get into it. So still we have to discuss about the anti-malarial drugs based on the how the clinically how they are useful, right? So based on clinical use, they are being divided into three basic categories where they are used, right? First one is radical cure. So radical cure is required for plasmodium vivax and ovale. From the starting of the lecture, I am aiming to tell you that the relapse which is occurring for only vivax and ovale, so this is due to the hypnozoites. So these hypnozoites which are stored in the liver, right? So this radical cure aims to kill these hypnozoites, right? So what are the drugs which are included in this radical cure are primaquine. So this primaquine is exclusively, it is very much effective against the exoerythrocytic phase, right? That is in the hypnozoites, it is very much effective for that. And it also has effects on gametocytes, that's different, but it's primarily effective for the exoerythrocytic phase. And its congener, that is tafenoquine, which is there, it is having high volume of distribution and long T half life, right? And the second category where the clinical use is implicated is a clinical cure. So that is clinically we have to cure the disease, right? As a doctor, it's our responsibility to cure the disease. That is the clinical cure. So it aims at the erythrocytic schizontocide. That is, it aims at the erythrocytic phase, that is RBC cycle, so that the clinical symptoms are being reduced. So here we have erythrocytic schizonticides. I already discussed they are having fast and they are slow. So the fast acting erythrocytic schizonticides are mefloquine and artemisinin, chloroquine, halofantrin, atowacone, lumefantrine, quinine. Right? So these are fast acting. Slow acting we have PPT, that is proguanil, pyrimethylene sulfodoxine, and tetracycline. So these are the three drugs which are included in the slow acting of the clinical cure, that is erythrocytic schizonticide. Now we have lastly, that is prophylactically used. So prophylactically we have two types of prophylaxis. I already discussed in the starting of the lecture where I discussed the life cycle of plasmodium. So here we have casual prophylaxis which aims that the sporozoite should not reach the liver. So it aims, that is prior to hepatic invasion, it interferes with the sporozoites to reach the hepatocyte, right? We have chemoprophylaxis which aims to kill the merozoites which are released from the liver, which are going to infect the RBC, so that the symptoms or the disease may not progress, right, or may not acquire the disease. So here we have prior to hepatic invasion, we have three drugs here, that is proguanil, pyrimethamine, and primaquine. So this proguanil and pyrimethamine are dihydrofolate reductase inhibitors that we need to remember. Chemoprophylaxis, we have two basic categories here, either for short duration or long duration. It depends on the person who is going to the endemic area. Here we are discussing that for short term duration, we use doxycycline 100 mg per day, a day prior to visit the endemic area, up to 4 weeks after return from the endemic area. This is the chemoprophylaxis for short term, that is less than or equal to 6 weeks. If the duration is more than 6 weeks, that is the duration extends more than 6 weeks, then we go with mefloquine, which is given weekly, that is mostly that is 4 weeks prior up to 4 weeks after returning from the endemic area. Okay, so this is 250 milligrams per week we will take, right? So this is about the classification of anti-malarials based on the clinical use, right? So this is the national drug policy for malaria, which is coming under National Vector-Borne Disease Control Program, which we will discuss in detail in case of SPM. When third year, we will discuss about this National Vector-Borne Disease Control Program. So in this program, we can divide this into uncomplicated malaria and complicated malaria, which is simple to understand, right? So what are the complications of malaria? We have already discussed them. So if they are present, then it is complicated malaria. If it is uncomplicated, then if there are no complications, that is uncomplicated malaria. First, we'll discuss about uncomplicated malaria. How to treat it? So first we'll go with, we have to divide the species again, because for Plasmodium falciparum we have sequestration, right? So first we'll go with the Plasmodium vivax, ovale and malariae. For this we'll first give chloroquine plus primaquine. Chloroquine for 3 days and primaquine for 2 weeks, which is a gametocidal. And then if it is non-responsive, then we'll go with artemisinin combination therapy plus primaquine for 2 weeks again. So this is what for Plasmodium vivax, ovale and malariae. If you observe, we will give primaquine as a gametocidal in every regimen. We can see there is primaquine. So why we will give primaquine is, it is a gametocidal. So we need to give the radical cure. I have discussed this before. So for radical cure of vivax and ovale, we need to give primaquine, right? So that's mandatory here. But in case of falciparum, we have banana shaped gametocytes in the peripheral blood smear. We have discussed in laboratory diagnosis. So for this, there is a slight difference in case of northeastern states and rest of India. First we will discuss about rest of India. In rest of India, we will use artesunate and sulfadoxine pyrimethamine, right? Whereas in case of northeastern states, we will go with artemether and lumefantrine. So this is the regimen for northeastern states. Why? Because in northeastern states, they are resistant to this artesunate sulfadoxine pyrimethamine regimen. Therefore, we have shifted them to artemether and lumefantrine, right? Now let us discuss about complicated severe falciparum malaria. How to treat it? So first we'll give the drug of choice for it is, with closing your eyes you can tell that the drug of choice is IV artesunate. So if it is available, then it's definitely IV artesunate. If it is not available, then what we have to do? We have to go with IV quinine, right? After 48 hours, we'll go with quinine, peroral quinine, clindamycin and doxycycline. Generally, we avoid quinine with respect to this artesunate combination therapy or artesunate, artemisinin combination therapy or artesunate, because quinine have more side effects as compared to this ACT, right? So this is all about how to treat the malaria. So if it is uncomplicated or if it's complicated. What is the treatment of malaria in pregnancy? So how do you treat malaria in pregnancy is, we have to divide again here species. That is, if it is Plasmodium vivax, malariae or ovale, then first we will try with chloroquine. Since the falciparum is resistant to chloroquine in India, we will directly start for the first trimester, we will go with quinine plus clindamycin, that is both 10 milligrams per kg, but quinine is 3 ID, that is 3 times a day, whereas clindamycin is BD 2 times a day for 7 days. So this is in case of first trimester. And here chloroquine 600 milligrams day 1 and we have 300 milligrams per week, right? Now I have doubt, that is, I told before that for uncomplicated, that is Plasmodium vivax or Plasmodium malariae, ovale malaria, we have to use primaquine. So Should I use primaquine in pregnancy or not? So the answer is no. So the primaquine is absolute contraindication in pregnancy. So we should not use primaquine in pregnancy. Whereas in second to third trimester, we'll go with ACT, that is artemisinin combination therapy, right? So this is all about the malaria in pregnancy. Now let us discuss about the individual drugs, that is chloroquine. I have discussed this chloroquine under fast acting erythrocytic hydroxide, that is Machal, right? Machal Q. So you can remember it like it is fast acting erythrocytic hydroxide and it has no effect on exoerythrocytic phase. I have discussed it a number of times in this lecture, that is what is exoerythrocytic phase, right? So it's not effective under exoerythrocytic phase. I think you are familiar with this exoerythrocytic phase, right? Now we have indications of this chloroquine. So what is the mnemonic to remember? I have a funny way to remember. So the mnemonic is Prem Dil, right? So we have Prem with for Dil, right? So it's a small way to remember. It's okay. So what is Prem Dil? See, P for photogenic reactions, and then we have rheumatoid arthritis, extraintestinal amoebiasis, malaria. How can we forget that? We are discussing that. And we have D for discoid lupus erythematosus, and we have I for infectious mononucleosis, which is also called as Kissing's disease, and L for we have lepra reaction type 2, that is erythema nodosum leprosum, right? So this is all about the exoerythrocytic zygonside chloroquine. Then we have side effects. What are the side effects? Normally, like any other drug, we have nausea, vomiting, diarrhea, gastric irritations, and then we have rashes. These are all common. So what is specific for chloroquine is we have ototoxicity and oculotoxicity. What is oculotoxicity it causes is it causes bull eye maculopathy and also cornea verticillata. Then we have QT prolongation and cardiac depression, and also we have hemolysis with G6PD deficiency patients. So with this knowledge that we have, we can easily extrapolate to the contraindications of chloroquine. So what are the contraindications of chloroquine is? One is G6PD deficiency. We have discussed just now. So G6PD deficiency is one of the contraindications. Next, second contraindication is with antacid. So we should not give chloroquine with antacid because it decreases the absorption. It decreases the absorption of the chloroquine. So we should not give it with antacid. And next we have P for porphyrias and also psoriasis. So these are the contraindications of chloroquine. So how can we forget the mechanism of action of chloroquine? Let's discuss it. So chloroquine is a basic drug which enters the RBC, right? So here what happens in RBC, we have hemoglobin which is degraded into hemoglobin, and this globulin is again reused, whereas heme, it is toxic to this malaria parasite. So for malarial parasite, the heme which is there, it is toxic, right? So since it is toxic to malarial parasite, it degrades it into hemozoin. So this hemozoin is less toxic or non-toxic to malarial parasite, and for this reaction the enzyme heme polymerase is useful. So heme polymerase is useful. Now what happens with chloroquine? This chloroquine will go and it inhibits this heme polymerase. So likewise it inhibits the heme polymerase and it forms the heme chloroquine complex. So this complex it destroys. So it destroys the plasmodial membrane. Right, so this is the basic thing and the mechanism of action of the chloroquine, right? Now let's discuss about the artemisinin combination therapy, right? So we need to discuss about the artemisinin combination therapy. So let us discuss about the last topic that we have left with is artemisinins. So these artemisinins are derived from traditional Chinese plant, that is quinkosau plant, right? So it's fast acting erythrocytic agenticide. So I have told the mnemonic Machal Q. So in that the artemisinins also comes under the fast acting erythrocytic agenticide, right? So here we have artemisinin, right? It's water soluble. From that we have three different drugs. That is, one is artemether, which is oil soluble, artesunate, which is water soluble, and arteether, which is injectable. So artemether we can give per oral, intramuscular, and rectal, and artesunate will give in all the forms that are given by the artemether. Plus we can give intravenous also. Whereas RT ether it is a injectable, right? So these two drugs active metabolite is dihydroartemisinin. So the advantages of this artesunate combination therapy. So every time when we give the artemisinin, we will not give the individual drug. So we give the artemisinin combination therapy. What are the advantages of this artesunate combination therapy, right? The first one is good tolerability. So the patient is good tolerable to this artemisinin combination therapy act, right? And also there is high cure rates and low recrudescence rate. I have told you that I told relapse. So I have told you relapse and reoccurrence and recrudescence. So these are the three different terms related to malaria. So relapse is with oval and vivax, right? I have discussed the hypnozoites which are transformed into sporozoites, and again the dormant states coming into the active form, right? So that is relapse. What is recurrence? Recurrence is nothing but the relapse and recrudescence. That is, again the mosquito comes and bite the human being, and again it infects with again he infects with the malaria. So that comes under the recurrence. Whereas recrudescence, what is recrudescence is with artemisinin and falciparum malaria. So we use artemisinin with complicated and also uncomplicated falciparum malaria, right? So in that, this artemisinin is a fast acting, right? It's rapid acting, right? So then there are some parasites or there are some falciparum malariae which are present, which are not eliminated, right? So that again they cause the malaria fever. So this type of reoccurrence, that is again appearance of the symptoms, is called as recrudescence. This is due to incomplete treatment, that is incomplete elimination of the parasites by this artemisinin therapy, right? So this is lowered with the help of combination, artemisinin combination therapy. Then we have inhibit parasite resistance. If you give only artemisinin, there is a high chance of developing the resistance, right? But if you give this combination therapy, then there is no chance of resistance. There is low chance of resistance, right? Then we have rapid clinical and parasitological cure. There is rapid clinical as well as parasitological cure. What are the different act which we have? That is artesunate 100 milligrams and mefloquine day 2 750 milligrams and day 3 500 milligrams, and artemether and lumefantrine 80 milligrams artemether and lumefantrine 480 milligrams, and then artesunate sulfadoxine pyrimethamine. So these are the different acts which we have. So this completes the malaria in detail, the microbiology and also pharmacological aspects. Like we have covered the first malaria, what is malaria, then we covered the life cycle of malaria, plasmodium that is, and then we go with the clinical features. We have discussed the laboratory diagnosis, we discussed the complications of malaria, and then we come into the treatment part, that is anti-malarial drugs. We have classified them based on mechanism of action, we have classified them based on the clinical use, how they are used, like radical cure, clinical cure, and also for prophylaxis. For prophylaxis we again divided them into casual prophylaxis and chemoprophylaxis. Then we go into the What is the national drug policy for malaria under National Vector-Borne Disease Control Program? Uncomplicated, complicated. We all discussed, and we also discussed the malaria and pregnancy, right? In first trimester, we'll go with quinine and clindamycin. In second and third trimester, we go with ACT, that is artemisinin combination therapy. Then we get into the individual drugs. We have discussed about chloroquine in detail, the mechanism of action, therapeutic uses, and adverse effects and contraindications. And then we discuss the artemisinin, that is artemisinin, artesunate, arteether, artemether, dihydroartesunate, and dihydroartemisinin. And we have discussed the advantages of ACT, that is artemisinin combination therapy, and all the forms of ACT we have discussed. So this completes malaria. Thank you.